Our today's lecture is about etiology of malocclusion. Remember in the previous lectures we discussed the etiology of malocclusion as a soft tissue. Today we're going to cover the local or dental factor toward the development of malocclusion. We're going to cover all these topics: natal or neonatal teeth, infra-occlusal primary teeth, primary failure of eruption, ectopic eruption, traumatic displacement of the teeth, supernumerary teeth, double tooth, and micro-dontia, macro and micro-dontia, thence invaginatus and amelogenesis and dentinogenesis imperfecta. So we're going to start with the natal and neonatal teeth. When we say natal, it means that the teeth present at birth. However, when we say neonatal, it means that the tooth erupting from the birth till the age of 30 days. As we know that the lower incisors is the tooth mostly affected, and usually the lower incisors erupted at the age of 6 months. However, these teeth erupted either at the birth or during the first month. Usually the mandible is affected more than the maxilla, and females are affected more than males. The etiology, usually it's suspected to have some familial inheritance, which mostly autosomal dominant, and that resulted in the tooth germ being migrated more to the surface, toward the surface in a premature manner. So basically the tooth erupted more soon or quicker than expected. Or sometimes the endocrine disturbances resulting from pituitary or thyroid gland dysfunction. These and other factors. The natal tooth may be supernumerary, and that's happened in 10% of the cases. Now, what are the complications of having a natal and neonatal tooth? First is the pain on suckling and the patient refusing to feed. Don't forget that this patient can have milk from the mother, and having a tooth at that early can hurt the mother and can hurt the baby as well. So that's kind of causing a problem. Usually these teeth come up without roots, and so they will be mobile in some cases. So there's a risk that this one will exfoliate and then the kid will aspirate this one. So usually if these teeth are mobile, the dentist sometimes, the pediatric dentist decide to extract it. Riga fida disease, which basically it's uncommon mucosal disorder, is characterized by continuous ulceration of the tongue, and that is caused because of the suckling movement. During suckling, the tongue is moving forward and backward, hitting the lower incisors, causing traumatic ulcer to the tongue, and that happens when have a natal or neonatal tooth. Then we go, this lecture we're going to discuss the etiology for the malocclusion, and in the interceptive lecture we're going to mention the management for these kind of malocclusion. So today's lecture is only about the etiology. Then we have something called the infra-occlusal primary teeth, and that's tooth that basically remain at its original occlusal plane, while the rest of the arch developed laterally and vertically, making it appear as submerged. So if we look here at this tooth, here is the E. So what's going to happen? That everything grows vertically and laterally, and this tooth is kind of ankylosed, it doesn't move. So everything is moving up, so this tooth will appear as if it is sinking. But the fact is that it is not sinking, it stays where it is, while everything else is moving upward. Now, that happened in 8 to 14% of the population. It has some familial history, which indicates some genetic background. These are more commonly affected than the E's, and it's 10 times more common to be seen in the mandible compared to the maxilla. So it's more common to the D, more common to affect the mandible. Now there's a classification for that one. It's got mild, moderate, and severe, and this classification depending on the relationship of the primary tooth to the contact point. So if the primary tooth is above the contact point of the neighboring teeth, whether it's E's or the E and D, or the E and the canine, or the 6 and D, so that means it's a mild infra-occlusal. However, if it's at the same level at the contact point, then we call it moderate. If it's below the contact point, we call that this is severe infra-occlusal. Now, why does this happen? Usually it's because of the ankylosis. And this ankylosis comes and goes, which means that we have ankylosis and then the ankylosis disappear. The ankylosis formed again and then it disappeared. Now, but why this ankylosis happened? Mainly we don't know. There's multiple theories trying to explain this one. Some of the like traumatic injuries to the Hertwig's epithelial tooth sheath due to chemical or thermal irritation, maybe a deficiency in the bone metabolism, disturbances in the bone root resorption. But really we don't know. But what we know is that we have bone resorption, ankylosis, and then this ankylosis comes and goes. When we have ankylosis, it means that the extraction is not easy. So this is something to keep in mind when we decide the management. But what is the features, what the clinical presentation of this infra-occlusal primary tooth? If you look at the picture here, we have an that's a kind of severe infra-occlusal tooth. So when that happens, simply the neighboring teeth will tip toward this place. So the canine in this case here will tip distally, and this is the 6 will tip, or maybe the E tip in the mesial direction, which result in reduction of the arch length. And in the future, that will result in crowding. And also, this tooth will not have a space. If we have a permanent successor here, we will not have a space for this tooth when it comes for the eruption. So we are losing the space. The other thing is the opposing teeth. The opposing teeth will over-erupt. So we have tipping of the neighboring teeth and over-eruption of the opposing teeth. So that will result in a space loss, as we mentioned, wedging of the primary tooth, as we can see here, and that will result in a problem with the access for oral hygiene, restoration, or even extraction when that happens. When we have this infra-occlusal tooth, we need to check if it's ankylosed or not. So usually we can do a percussion test to check about ankylosis. Might take an periapical just to check if the permanent tooth is there or not. Then we're going to talk about, we finished now infra-occlusal primary tooth, we talk about failure of eruption. So primary failure of eruption or secondary failure of eruption. Now, failure of eruption is defined as failure of the permanent tooth to erupt or cessation of initial eruption with no obvious local systemic causative factor. So basically you can see here, for example, in this photograph, that the molar has penetrated the mucosa and then all of a sudden it stopped. This cessation of eruption has no reason. There is nothing can explain why this tooth has stopped. No supernumerary tooth, no systematic factor, no local factor. Then this is, we call it failure of eruption. Now, if this failure of eruption happened after the tooth has penetrated the mucosa, we call this as a primary failure of eruption. However, if this happened while the tooth is still within the bone, it did not penetrate into the oral cavity, we call it secondary failure of eruption, as we can see in this radiograph. And that's what we call it, primary and secondary failure of eruption. Now, the etiology for the failure of eruption, it can be due to the inherited disorder. There is strong evidence suggesting that there is a mutation in the parathyroid hormone receptors, but still again, these kind of thing that it has unknown kind of clear-cut etiology. Now the incidence, it's more affecting the females comparing to the males, and it more commonly affecting the molars. Usually the features for this failure of eruption, usually affected posterior tooth, the bite distal to this one will be open. So you're going to have something similar to this one. So you're going to have a lateral open bite. Affected tooth might have each initially erupted into the occlusion and then stop or fail to erupt. It might be associated with the infra-occlusal primary teeth, in particularly ease. It could be unilateral or bilateral. Permanent teeth may become ankylosed after the failure of eruption. So basically they start moving and then they stop and they maybe become ankylosed. And even if the tooth is not ankylosed at the examination time, if you try to move this failure of eruption tooth, it will lead to ankylosis. So basically if we have a tooth like this and you do the percussion test and you see that, okay, this tooth is not ankylosed, there's no metallic sound, you take an periapical and the lamina dura is intact, so there is no obliteration of the lamina dura, you say, okay, fine, I'm going to try moving this tooth. Immediately you're going to have ankylosis. Presence of this failure of eruption can affect the vertical growth of the face. How can we diagnose failure of eruption? Diagnosis is done purely by exclusion or retrospectively. What does that mean? Because basically in failure of eruption, there is no reason. We don't know why the tooth is not erupting. So simply you need to exclude any other causing factor for failure of eruption. And then after that, if you did not find any cause, then the cause will be the failure of eruption. And that's the diagnosis, we call it by exclusion. So you look for dilaceration of the roots, you look for supernumerary tooth, you look for fibrosis of the mucosa covering the tooth. If there's nothing left and there is no cause for this failure of eruption, then we call it primary or secondary failure of eruption. So now we reach to the ectopic eruption. We discussed natal and neonatal teeth, infra-occlusal primary teeth, primary failure of eruption, and now we're going to cover the ectopic eruption. Now there is certain terminologies that we need to know. The first one is the socket and the crypt, the difference between them. Then the socket is the bony space with a maxilla or mandible that supports the root of an erupted tooth, while the crypt is the bony space immediate in the mandible or the maxilla containing the developing tooth. So this one is an erupted tooth. This one we call it crypt, while this one we call it socket, supporting the erupted tooth. Also need to discuss the difference between impaction and ectopic. Now, impacted tooth or impaction of a tooth is the prevention of a complete eruption of a tooth into the normal function position, either due to bone, tooth, fibrous tissue, or lack of space. We call this impacted tooth. While ectopic tooth is a malposition of the tooth due to congenital factor or displacement by the presence of pathology. So basically, just simply the tooth is shuffled to the place other than its original place. Now, impaction can be caused by, as we mentioned, lack of space, bony obstruction, fibrous tissue, and ectopic position. So basically, let's assume that we have the tooth pod of a 5 that is displaced up high in the palate. When the 5 erupts, it's not going to erupt to its normal position. We call this impacted 5, and the cause of the impaction is because of the ectopic position of this tooth. When this tooth erupts, we call it ectopic because it's erupted in a place other than its place. It's malpositioned tooth. Now, what is the causing of ectopic eruption? Sometimes it's ectopic crypt, like the whole crypt, it's positioned in abnormal position. That may be because of pathology or maybe because of genetics. This crypt is not in the normal position. And that can lead to rotations, maybe if the tooth is ruptured, misplaced development, impaction if that's far away and the tooth didn't make it to erupt, and sometimes transposition if the tooth erupted in exchanging the position with another tooth. We call it transposition. We're going to cover it later. This can be seen particularly in the cases of the lower third molar, upper canine, and lower second premolar. These are the most common teeth to have ectopic eruption: molars, canines, and second premolars. However, the second premolars is the one that will improve in the position spontaneously. So in the clinic, if you see a patient with a second premolar, you usually wait and observe, because usually this tooth tries to spontaneously correct its position. I was talking about the ectopic eruption. I mentioned now the ectopic molars. So that's a kind of the ectopic eruption. So what is ectopic permanent first molar? As you can see in the radiograph here, it's when the local eruption disturbance where the first permanent molar is blocked from complete eruption by the E, which is usually resolved permanently on the distal surface. So basically, instead of the 6 erupting in its position completely normal, it's erupting in the ectopic position. It's not in the normal position. It moved forward. So it become wedged under the E. And as the tooth erupting, it causes resorption of the root of the, causing resorption of the root and maybe the crown reaching the bulb. Now, this ectopic eruption have different severity. It could be only overlapping the mesial marginal ridge with minimal resorption, and we call this mild, or it can be severe to the point that it's causing resorption to the root, reaching to the bulb, maybe causing bulbic when it's severe. Now, it affects about 4.3% of the population. In 66% of the cases, it's reversible, which means that this tooth will correct its position spontaneously without the need of any intervention in 66% of the cases. And usually these are the mild cases. There is a high incidence of sibling to be affected in 19.8% of the cases. Again, that indicates that we have a genetic factor. Maxilla is affected more than the mandibles. Males here in this case are affected more than females. Right and left side are the same. Unilateral and bilateral is 50-50. However, the presence of a cleft palate increased the incidence to be 4 times to have impacted or ectopic first permanent molar. Now the etiology is kind of multifactorial. You're trying to find out why the 6 got impacted under or ectopic underneath the E. It could be that the increase the mesodistal width of the 6 itself. It could be increase the mesial eruption angle of the 6, so it got trapped under the E. It could be small maxilla, so there's no space for the 6 to erupt, so the 6 now become trapped underneath the E. Or maybe the maxilla itself is retrognatic, it's posteriorly positioned so that the 6 kind of moved forward and become impacted underneath the E. What are the effects now? We know that we have ectopic eruption of this first molar. What could be possible effect? Now, it's rarely symptomatic. As we said, in 66% of the cases, it's corrected spontaneously. So it's really rare to have symptoms from this tooth. However, when the symptoms happen, usually these symptoms are related to the E, the damage that the 6 can cause to the E. So maybe because it's invading the root space, it can cause pulpitis of the E. It might cause a neuralgic pain related from the 6 being pushing underneath the E. And sometimes maybe we're going to get abscess and necrosis from this E. Also, resorption of the root might result of a premature exfoliation of the E, and then that will result in more mesial migration of the 6. That will result in reduce of the space and the arch length, and then when the 5 come to erupt, there will be no space for this 5 to erupt, and we're going to have impacted 5. So that depends on the severity of the amount of the impaction. So as we mentioned before, 66% of the cases will be spontaneously corrected, and in most of the cases it's asymptomatic. However, when the symptoms happen, usually related to the damage that the 6 can cause to the E. Now the diagnosis can simply be done by looking at the eruption path where the distal cusp emerge before the mesial cusp. So if you examine the patient and then you see the mesial cusp is not erupted yet while the distal one erupted, which means that there is some maybe ectopic eruption. Unilateral and bilateral delay by 6 months, which means the right side erupted, then more than 6 months later the left side has not erupted yet. Now definitely this diagnosis can be confirmed by taking a periapical X-ray or OBG to confirm the position of the 6. Now we're still talking about the ectopic eruption, and now we're talking about the transposition, which means the positional interchange of the 2 adjacent teeth, or the development or eruption of the tooth into a position normally occupied by a non-adjacent tooth. So if you look here at the photograph, you can see here that we have central incisors, lateral incisors, and then we have premolar, and here we have canine. So usually we have canine and then premolar. So we call this a positional interchange between the canine and the premolar. We call this transposition, which is type of the ectopic eruption because the canine erupted in not its place. Now, classification. This transposition can be classified either to complete transposition, in which case the crown as well as the root have exchanging the position with the transposed tooth. So, for example, here as you can see in the OPG, this is the lateral incisor and this is the canine. So, the canine is taking the place of the lateral incisors, crown and root all together. So, basically, this one we call it complete transposition. While we have another one called pseudo or incomplete transposition, occur when the crown of the adjacent teeth have changed their position, however the roots they are not. For example, if you look here, you can see that the crown is going to this direction while in on the lateral, while the canine is going in this direction, however the roots are in the right place. So if you look here, the crown, we have central, canine, lateral. But the crown is distal, is mesial, in the incorrect position or the transposed position. However, the root it's in the correct position, and the same as here. And these cases definitely, when you have a pseudo transposition, are much easier to be corrected compared to complete transposition. Now, what is the etiology? Again, it's multifactorial. Both genetic and environmental factor has proposed as a cause. because this kind of malocclusion may be associated with other anomalies like hypodontia, big shape maxillary incisors. And there is a frequent association with other dental anomaly that will give you, again, a strong argument that this is a genetic background. Now, another way of classifying or giving code to the transposition is by using three components, like this one here. I'm going to show you how to do it. The first part will describe the jaw in which this happened. So if you have a maxilla, you write MX. When you have mandible, you write MN. Then you write which transposed tooth, so which tooth has moved from its original position. And here we have coding for the teeth. The first premolar is called P1. Second premolar is called P2, while the canine is called C. Molar is called M1, and second molar is called M2, while the central incisor is called I1, while the lateral incisor is called I2. So now if the canine is moving to this place, and that happened in the maxilla, so the first component we write MX, and then which tooth has moved or transposed is the canine, so we write then C. And then it took the place of the first premolar, so then we write P1. So that will be the code or the classification for this kind of the transposition. Now, the prevalence is not that much, it's 0.33%. However, it's more common in the maxilla. 88% is unilateral. It's more common in the left side compared to the right side. And the most common one is the maxillary, in the maxilla where the canine take the place of the first premolar. That's 71% of the cases, while the second most common one when the maxillary canine take the place of the lateral incisors. Now we're still in the ectopic eruption. So we mentioned now the 6 ectopic eruption, we mentioned the transposition. Now we're going to mention the impacted canine. So the canine that is prevented from eruption into its normal functional position by either bone, tooth, or fibrous tissue is called an impacted canine. Now usually if you have an absence canine, it's about 0.08%, which is very rare to have a missing canine. So if you have a patient with unerupted canine, usually it's more often or more common to be impacted rather than to be missing, because it's seen in 2% of the population, while the absence canine is 0.08%, which is less than 1% of the population, definitely. So the canine, if you see patient with no canine there, you expect to have this canine impacted rather than missing. Now the most common form of the impaction in 61% of the population is palatal, then in the line of the arch in 34% of the population, and the least common type is the buccal impaction in the 4.5% of the population. It's more often to see it unilateral compared to the bilateral, so it's 4 times more to see unilateral impaction of the canine. Female are more affected than male in 70% compared to 30% of the population. And usually it's increased incidence for impacted canine when you have a patient with a class 2 division 2 malocclusion. Again, a class 2 division 2 has a high genetic background. Canine has a kind of genetic background. That's kind of why can explain why we have these two kind of malocclusion together. Now 12.5% have a root resorption when using 2D imaging. However, 45% has a root resorption. We are talking about the canine causing resorption to the lateral incisors. Now the impacted upper canine, usually you need to know the sequence of eruption of the canine. You need to know the age of the canine exactly. Now the calcification happened at the age of 4 to 5 months. The upper canine erupted by the age of 11 to 12, while the lower erupted by the age of 9 to 10. By the age of 10, the upper canine should be palpable in the labial sulcus. So you need to feel this canine. Now, if by the age of 11, you can't feel the canine, then this canine might be palatally impacted and you need to consider doing an interceptive treatment, and that will be discussed in another topic. However, usually when we have an impacted canine, we expect to have a generalized delay in the dental development on that patient. Now, what is the etiology? Why do we have impacted canine? Now, we have multiple theories trying to explain that. Now, the first theory is the genetic theories. And this genetic theory explaining mainly the palatally impacted canine. Why do we have palatally impacted canine? Basically, it has the genetic theory saying that we have a polygenetic inheritance. And as we mentioned before, we see more palatally impacted canine with the class 2 division 2 malocclusion. And when you have kind of more than one form of anomalies come together, that suggests that we have a genetic background of this problem. Familial history as well, or familial tendency, so it's quite often to see siblings having impacted canine. Again, that indicate a genetic factor. Females are more affected than males. Again, that helps to the theory that genetics has a role to play in this issue here. So that's the genetic theory. And again, remember that genetic theory explains mainly the impacted canine in the palatal side of the arch. Long path of eruption. Now, why the canine is impacted while, for example, the central or the lateral incisors are not? Simply because the canine, one of the theories say, okay, the canine is calcified near the base of the nose, and then it moves all the way down to its position. So that's long path of eruption might result in the impaction. The tooth pod itself is ectopic. So, for example, if the tooth cell pod itself, instead of forming in the normal position, it's formed far away, that resulted in impaction of the tooth. The guidance theory. Now, what happens that the roots of the lateral incisor, this theory states that the roots of the lateral incisor, the distal side of the root, is giving a guidance for this canine to erupt. And when this lateral incisor is missing or big shaped, what's going to happen is that the canine will lose its path and they will not erupt. So, for example, here, if you have this patient, we have a missing lateral incisor on this side, so the canine is here. It's lost its way. No one is guiding the canine. While on this side here, because we have a big shaped lateral, which means that we have a narrow root, therefore the shape of the root is not normal. So again, the canine missed its path and is not erupting in the normal position. We call this a guidance theory. That's another theory trying to explain the palatally impacted canine. Now, dentoalveolar disproportion, which basically crowding. Now, 83% of the buccally impacted canine has a crowding, while 85% of the palatally impacted canine had sufficient space, meaning no crowding. So basically, the main etiology for the buccally positioned canine is crowding. And that's because simply the canine is the last tooth to erupt in the arch. So if we have a space loss, what's going to happen is that the 4 will erupt, it will find space, 5 will erupt, will have space. Now when the canine is trying to erupt, there is no space left because it's the last tooth to erupt. So what's going to happen? It's either the canine will stay impacted but not in the palatal direction, in the buccal direction, or it will erupt ectopically in the buccal sulcus. So either of them. So when we have crowding problem, the main etiology for it will result mainly in buccally impacted canine, while genetic and guidance theory, long path of eruption, they mainly explain the palatally impacted canine. So we finished about the impacted canine and the ectopic eruption, and when we discuss the traumatic displacement of the tooth. Now, if you can see to this photograph here, you can see that this tooth is a primary A. And the color is discolored. The color is kind of grayish in discoloration. This tooth is a normal central incisor, permanent, while this one is a primary tooth. So what happened to this patient? Simply, the trauma resulted in a displacement of this primary tooth in upward direction, intrusion. So don't forget that here we have a permanent successor lying underneath this one. Now this trauma resulted in a necrosis of the primary tooth. But what if the effect on the permanent tooth? Now, the effect of the permanent tooth depends on the stage of the crown formation. Now, if the crown has completely formed and the root is not yet completely formed, this trauma, this intrusion, might result in a stopping of the development of the root. So basically, the crown is developed completely, but the root is not yet. This intrusion trauma will result in displacement of the primary tooth within the socket, hitting the underlying permanent tooth. That will result in stopping their root formation. That's one option, and that's the least common one. But the most common thing that this trauma will result in changing in the direction of the growth. So now the root formation will continue, but it will continue with an angle. This angle we call it dilaceration. So if you look at this X-ray, this is for the same patient, you can see that the central incisor, it is as if it is looking at us immediately. Now this trauma resulted in a bending angle. That angle resulted in the tooth kind of having this kind of appearance. So now we call this dilaceration. Okay, now if the trauma happened while the crown is forming, it's not finished yet, we might have something like this, which is basically the disturbance in the crown formation resulting in hypoplasia, as we can see in this photograph. And that's taken us to discuss the dilaceration. This is a photograph of a dilacerated tooth. Now, dilaceration basically it's the difference between the angle of the crown and the root. Now, usually it's associated with the central incisor. That's the most common tooth to be affected. However, it can be associated with the trauma, as we mentioned before when we have intrusion. However, this dilaceration can be seen without trauma, but most commonly it's associated with trauma. As we said, 22% of the cases due to the trauma with palatally positioned crown. If severe, it will cause failure of eruption and may potentially require extraction. However, if it's mild, we might be able to bring this tooth into the line of the arch. Now think about it, this one is a very severe one. If I align this tooth, the crown, correctly and bring it down, this root will hit the neighboring teeth in the way down and when we align this tooth. So if the dilaceration is mild, we can simply align the tooth. If it's severe, we have to extract this tooth. We're still on this long list of the local factor. We reach here to the supernumerary teeth. Now, supernumerary teeth is a tooth or a tooth-like structure which develop in addition to the normal series of 32 teeth. Now, usually it's affect 1 to 2% of the population. It's 80% occur in the anterior maxilla, so most commonly it is in the maxilla. Males are more affected than females, twice. Most common cause of failure of the eruption of the central incisors is due to supernumerary. Now we are talking about this. If you see a patient with unerupted central incisor, it could be impacted, it could be missing, or it could be ectopic, right? But the most common cause is that impacted due to supernumerary. So when you see an unerupted central incisor, the first thing come in your mind that a supernumerary blocking the eruption. While the canine, if you see a patient with unerupted canine, the most common cause will be that the canine is ectopic or impacted without any supernumerary. If you see a patient with unerupted lateral incisor, the most common cause that this one is missing. So that's kind of the different behavior between the different teeth. 10% of the midline diastema are caused by the supernumerary. So, and we're going to see later that these supernumeraries sometimes cause displacement to the teeth, preventing the closure of the median diastema. So, whenever you have a patient with a median diastema, you have to exclude the possibility of having supernumerary causing this median diastema. Rarely to see any primary supernumerary in the primary dentition. Now, supernumerary teeth associated with many syndromes like Down syndromes, cleidocranial dysplasia, cleft lip, palate, and sometimes Gardner syndrome and Ehrlich-Van Creveld syndrome. Now, the etiology, as we mentioned, it is a multifactorial. It could be environmental and genetics. There is multiple embryological theories. We call embryological abrasion theories, including the dichotomy of the tooth pod. So the same tooth pod have separated into two. One, hyperactivity of the lamina dura, remnant of the epithelial cells, supernumerary dental germ. It's all embryonic, embryological theories trying to explain why we have supernumerary tooth. The other theory is called the progress zone theory, which basically suggests that the progress zone of the dental lamina at the end of each tooth series give rise to the supernumerary tooth. So, for example, we have more commonly to see a supernumerary associated with the lateral incisors because it's the last of the series of the incisors, second premolar and third molar because it's the last tooth in each series. As we mentioned, genetics is a good is a factor for the etiology for the supernumerary. It's good multifactorial, again, genetics and environmental one. Now, what are the clinical signs of the supernumerary? It could be asymptomatic and diagnosed by chance. Quite often, see patient coming for orthodontic treatment, there is no symptoms, you are taking just regular radiograph and all of a sudden you find a supernumerary tooth. So that could be asymptomatic, causing no troubles. However, it's not that all the time. Now, sometimes the presence of the supernumerary will result in displacement of the tooth, causing spacing or median diastema. Or sometimes it will displace the tooth itself, so you can see that the tooth is rotated or proclined. So this kind of type of supernumerary, it stays there. It does not prevent the eruption of the tooth, but it causes spacing or displacement of the tooth. If these supernumerary erupted into the mouth, they might cause crowding and irregularity, as we can see here when we have an extra premolar. There is no space for this extra premolar. It's erupted bilaterally or lingually in this case, and then it causing crowding and irregularity. And sometimes these supernumerary teeth can prevent and block the eruption of the permanent teeth, and the central incisors are the most common teeth to be affected by that. So they will prevent the eruption of the central incisors. Now, if we're going to classify the supernumerary, they can be classified either according to the location where they are in the mouth or according to the morphology. If we're going to classify them according to the location, if they're located in the anterior maxilla, they're called mesiodense. If they are located at the premolar area, they're called parapremolar. If they are found at the area of the molars, we call them paramolars. So that's a classification according to the location. But the most common classification that we use is according to the morphology. Okay, the first one is called the conical supernumerary. It's a small, big shaped tooth. It represents 75% of the supernumerary, so it's the most common supernumerary. Usually, the root will develop and may erupt or stay deep. So you can see the tooth is erupting or it will stay where it is. And usually, the tooth will have a root with it. Little effect on the permanent incisor eruption. As we can see, it usually does not block the eruption. It does not cause impaction. It either causes nothing, as we can see here, or it can cause median diastema or displacement of the teeth. If sometimes it erupted, cause irregularity if it erupted to the mouth. Usually the theory that these one develop as a mesial extension from the dental lamina. The risk for cystic formation is very low. So if you have a patient with a supernumerary tooth that is conical and you accidentally diagnose this one, there's no need really to extract this supernumerary unless it is interfering with your treatment. Other than that, you can just keep it under observation. The second type of the supernumerary is called the tuberculate supernumerary, and it represents 12% of the supernumeraries. And usually it comes like a barrel shape, like a barrel, as you can see here in this photograph. It's like a barrel shape, and usually it comes in pairs, in two of them. It's more often to see two of them at the same time. And this one is mostly causing impaction of the incisors. It's not like the conical, it's opposite to the conical. Usually they prevent the incisors from eruption and they cause impaction of the central incisors in a 1:5 ratio compared to the conical supernumerary. So the tuberculate supernumerary are more able to block the eruption of the, more commonly associated with blocking of the eruption of the central incisors. Now the third type is called the supplemental, like a twins. It resembles the morphology, the crown morphology of the adjacent teeth. So it's exactly the same. And usually this one found at the end of each dental series, for example, lateral 5 and 8. So that one will be something similar to that. It's like copy and paste, as we call it, supplemental supernumerary. The last kind is called, the type is the odontome, and it represents 6% of the supernumerary. And we have two types of these odontomes. We have complex and compound. Complex is diagnosed round mass of dentine, bulb, and enamel, like this one. So you can see it's a mass. It's a mixture of dentine, enamel, and bulb. While the compound is a mass of a discrete denticles, a small denticles that each of them has dentine, enamel, and bulb. So like this one. Now, complex Supernumerary are more commonly causing impaction. In 50% of the cases, they cause impaction of the teeth, while the compound are less causing the impaction, which 1/3 of the cases, or maybe 33, or like 1/3 of the cases with compound will have an impaction. Still high, but it's less than the complex one. Luckily, the compound are 4 times more common than the complex odontome. So by that, we finished the supernumerary teeth. Then we move to the double teeth. So what do we mean by the double teeth? This one is the hypodontia first and then the double teeth. So congenitally missing teeth, when we have a tooth that is not there, that usually result from disturbances due to during the initial stages of the formation of the tooth, the initiation and the proliferation. So we call it, when we have a tooth loss except the third molar, we call this hypodontia. While if the teeth that are missing are more than 6 teeth, we call this oligodontia. When we have all the teeth are missing, we call it anodontia. So if we're going to define it, we call hypodontia as a developmental abscess of 1 or more teeth, excluding the 8. It's mostly affecting the permanent teeth, 20 to 30% of the case of the third molar, 3% of the missing 5s, 2% missing lateral incisors. So it's more often to see a missing 5, lower right, lower 5s compared to the upper laterals. And then you have the mandibular incisors, which is less than 1%. Left side is affected more than the right side. Females again are affected more than males. There is similar percentage of missing teeth in the maxilla and the mandible. The MSX genes is involved in this one. However, here you just need to know that it varies in the different areas of the world, the percentage of the hypodontia, which indicate strongly a genetic background. For example, in Africa, 13% of the population, they have a hypodontia, while in Europe, 7%, in Asia, 6.3%. So it depends on the area and the geographic place that we have the percentage of the population who having a missing teeth. UK population have a 5.3 to 5.6% of the population. And it's not only how often you can see the hypodontia, is the type of the hypodontia as well. So for example, as you can see here, the 5s, missing 5s are more common in the Caucasian population compared to the central incisors, while the Asian population has more common missing lower incisors compared to the 5. So genetics play here a major role, because the ethnic diversity change or affect the percentage of the hypodontia. Clinical feature of hypodontia, usually hypodontia is associated with microdontia, and as we mentioned, we have the guidance theory. So if you have a missing or small lateral incisors, you might have an ectopic canine. So general feature hypodontia, it might be associated with microdontia together with the hypodontia and ectopic canine. When we say microdontia, it means a smaller teeth. It could be associated with syndromes like Down syndromes, ectodermal dysplasia, cleft lip and palate, hemifacial microsomia, and Gardner syndrome. It could be associated as well with hyperparathyroidism, rubella, and radiation. Now, maybe it will be having a delayed or asymmetrical eruption of the permanent teeth. So basically, if you have retained infra-occlusive primary teeth. So if you have a missing tooth, we have a hypodontia. So meaning that one side will have a retained primary tooth. We call this asymmetrical eruption of the permanent teeth. So for example, if you have a missing 5 in the lower right side, so the lower left side we will have the 5 erupting, while in the right side the E is still there. We call this asymmetrical eruption of the permanent teeth. And then the primary tooth will be retained. So we have a retained, it could be infra-occluded primary tooth. Okay, usually the teeth are conical and usually reduced in the crown morphology of the permanent teeth when we have a hypodontia. And now we move to the double teeth. Sorry about the slides have changed. So the double teeth here is basically excessive, the mesodistal width of a clinically crown, sometimes called macrodontia. And we're going to cover the macrodontia. Now, macrodontia is a terminology, it's a big umbrella meaning big teeth. And the double teeth is something different. It's excessive mediastal width. We're going to see why micro-dontia is different from double teeth. Now, double teeth means that we have different types from them. Like it could be fusion or gemination. And the fusion, it's partial or complete union of dentine and or enamel of two or more separate tooth germ at some stage of the development. So basically, it's as simple as there's two teeth fused together. And this fusion could happen at the level of enamel or enamel and dentine or enamel and dentine and bulb. Now, the gemination is that the tooth is attempt to separate. So we have a tooth bud, and this tooth bud trying to separate into two teeth. Now, what distinguishes the double teeth and distinguish it from the microdontia is this line here that they present on the labial surface. So this is a big tooth, so it could be, say, yeah, this is a microdontia. But then why it's called double teeth? Because we have this line. It's like two teeth fused together, or two teeth geminated from one tooth bud. That's why we call it double teeth, because of this line on the labial surface. The other type of double teeth called concrescence, which basically the joining but at the level of the cementum. That will obliterate the periodontal ligament. We will not have a periodontal ligament in this area. However, the crown width is not increased. It's the same because the fusion happened at the level of the roots. So fusion, usually it happens at different level. It could have an enamel only or enamel and dentine, and sometimes that will fuse to the level of the pulp. Gemination, usually they have one pulp chamber because it's one tooth that is separated into two. The concrescence, joining of the adjacent teeth via cementum, that will obliterate the periodontal ligament and the crown is not affected. And the roots of the pulp as well, they will have two separate pulp chamber. Etiology is unclear, can be associated with syndrome like facial hyperplasia. It's seen in about 1.9% of the permanent dentition, commonly affected the incisors, particularly the central incisors more commonly, can occur in the primary and vertical permanent dentition. Now, fusion can occur between a tooth of the normal series or a tooth with a supernumerary teeth. Now, the clinical presentation, usually this tooth is big and we have a vertical groove that extended toward the gingival sulcus. And this one, we have a poor aesthetic. So basically, usually these patients attended the clinic complaining about the poor aesthetic of this clinical crown because it's very wide. We have a groove dividing this tooth. It can be symmetrical, in which we have two teeth on both sides. Now, if due to the fusion, if this double tooth is caused by fusion, we are expecting to have a hypodontia, a missing teeth, because, for example, this central incisor fused with this lateral incisor. So at the end, we're going to have a missing tooth. However, if this fusion happened between a permanent tooth and a supernumerary tooth, then we don't have any missing teeth. We can say, okay, that the teeth has a full set number. If gemination happened, then okay, then the number of the teeth is the same because simply this one tooth is trying to geminate to have two teeth. And that's why it's really difficult clinically to distinguish between fusion and gemination. Usually we just call it fusion and gemination because simply if you measure the teeth and you find hypodontia, then you say, okay, this is a fusion. But if you don't have a hypodontia, you can't be 100% sure that this is gemination because simply it could be fusion with a supernumerary tooth. Now the pulp chamber and the root canal can be joint and can be separate. As we can see here, you can see that the the pulp chamber are separate, while here the pulp chamber are fused together. And that can be happen and seen in the fusion and in gemination. Now, so the possible problems with the double teeth, the poor aesthetic is number one. As you can see, it's a big tooth. We're going to lose the arch link. We're going to have crowding because simply you have a bigger tooth occupying a big space. When we treat this patient, we're going to have a tooth size discrepancy, so we will never have a perfect fit of the occlusion. Now, at this line, we will have food entrapment, so we're going to have caries. Because it's a big tooth, we might have a periodontal problem. We might have an eruption problem as well because of the size of the tooth. So now we managed to finish double teeth. Now we go to the macrodontia and the microdontia. So when we say macrodontia, it's a condition in which any tooth or teeth appear larger than normal for a particular type of tooth. Now that is macrodontia. We don't have a groove. We don't have two teeth fused together. That's the difference between macrodontia and double teeth. Double teeth, yes, it is a big tooth, but it's caused by fusion or gemination. You can see vertical groove. You can see two teeth together, while this one is a big tooth. Now the macrodontia can be true in which that all the teeth are bigger. And this is rare, and it's very extremely rare, and it's usually seen in patients with gigantism. Okay. However, it's more common to see an enlargement of a single tooth, to have a macrodontia of a simple tooth that will be usually caused by the problem or disturbance in the morpho differentiation. However, you should be remembered that you need to distinguish between macrodontia and double teeth, and macrodontia and turodentism, in which basically the tooth has a big pulp chamber, not a big crown, just the pulp chamber is bigger. Okay, or sometimes when the jaws are smaller and the teeth are crowded, so the jaws kind of mislead you, making you think that the teeth are macrodontia. Then we have to talk about the microdontia, which basically the condition in which teeth appear smaller than normal. So if you can look at the teeth, you can see that the teeth are smaller than normal. It could be generalized, involving all the teeth, or it could be localized, involving single teeth. Now, if it's going to involve single teeth, the most common tooth to be affected is the upper lateral incisor, and it's quite often to see a big shaped lateral incisor, small or even a smaller one, and then the third molar, and then the lower five. These are the most common teeth if it affected only single tooth. But if it's generalized, it will affect all the teeth. Now, the hypodontia can be classified in three types. The true generalized microdontia, in which the teeth are truly small. That could be caused by genetics, it's just a smaller teeth, or maybe it's associated with a syndrome like a pituitary dwarfism. And the other one is relative microdontia, which basically the jaws are bigger, the teeth are normal size, but we have spacing. Because simply the jaws are big, it gives you the impression that the teeth are small. That's why it's called relative. Or the microdontia of a single tooth, and we mentioned that the most common tooth to be affected is the lateral incisors. The etiology of microdontia, again, it could be a combination of genetics and as well as environmental factor. Females are more commonly affected by microdontia and hypodontia, and there is association again between hypodontia and microdontia. Usually patient with hypodontia has a microdontia. Female have more commonly microdontia compared to the male. Then we're going to talk about dense invaginatus, which basically a malformation of the tooth resulting from the folding of the dental papilla during the tooth development. So basically, during the tooth development, this enamel, it will fold it inside, and then here there will be an area of food trapment, so we're going to have maybe caries. Sometimes that will be communicated into the pulp chamber, causing necrosis of the pulp. Now, the last thing to discuss is amelogenesis imperfecta and dentinogenesis imperfecta, and then tetracycline staining. Now, amelogenesis imperfecta is a condition in which we have a problem with the production of the enamel. This production of the enamel could be a hypoplastic or hypomineralized. The difference is that in hypoplastic, there will be no production of the organic component. And the hypomineralized, there will be production, but there will be no enough mineralization. Either way, the enamel will be defective, and this enamel will be easily chipped from the tooth surface. And as a result, bonding with these patients is extremely difficult because the enamel is not good. It can't be bonded correctly. So that can be challenging to treat patients with amelogenesis imperfecta. And then we have dentinogenesis imperfecta, in which the enamel is normal, but the dentine is not. And when the dentine is not normal, the enamel will not be bonded correctly. So we'll have all the enamel chipped away during the treatment, during the course life of this patient. And usually these patients with dentinogenesis imperfecta, they have a discolored teeth because they lose the enamel, and you see the color of the dentine, which kind of discolored sometimes. So you're going to see a discoloration, the enamel will be gone as well. So again, it's the same problem that we face with amelogenesis imperfecta and dentinogenesis imperfecta as well. We can't, or it will be difficult to bond brackets. Last thing to discuss today is the tetracycline staining, and that's less common at the moment, usually because the stains now that the tetracycline used to be in the past given to the kids at the age of 2 or 3 years, and that is the stage of calcification of the permanent dentition, and that resulted in staining being trapped inside the enamel and dentine, which is now kind of very uncommon to be seen. That's all for today. Thank you very much for listening.